Welcome everybody to day 3 of the October Start virtual orientation session. My clock says 1 o'clock and I see a number of people joining now. So we're going to get started with just some brief housekeeping. Okay, so welcome. Today's session is focused on doing START work through the lens of cultural competence, and it's intended for START team members. Before we get started, let's just review a few important housekeeping notes. First and foremost, I do want to mention that a number of our team members are joining from areas that are currently being affected by a hurricane. We have taken all necessary measures to ensure a smooth event today, but we ask for your patience if there's any brief disruptions. Just know that we are on top of it. Please remain muted with your cameras off for the duration of today's session. If you experience technical difficulties during today's session, please just send a chat to Anne-Marie Ashford. Chat will open publicly during designated periods throughout today's presentation. Closed captioning is available, and to activate, please click the CC Live Transcript button at the bottom of your Zoom screen. Materials for today can be found on our website, and we'll post a link in the chat. Today's program is broken into 2 segments. First, we'll have a training provided by Dr. Jill Hinton, Andrea Caoili, Dr. Karen Weigley, and Dr. Jennifer McLaren, who will put what we've learned over the last 2 days into the context of START practices. This will include a brief recap, some training, and an opportunity for small group discussions via breakout rooms. This first segment will bring us to our break that begins at 3 p.m. Eastern and 12 p.m. Pacific. The second segment, beginning at 3:30 p.m. Eastern, 12:30 p.m. Pacific, is an opportunity for you to hear from a panel of START team members from across the country about how they view and implement cultural and linguistic competency approaches. The panel will close out today's session, which ends at 5 p.m. Eastern, 2 p.m. Pacific. I'd now like to introduce today's presenters. Dr. Karen Weigley is a clinical psychologist with over 30 years of experience working with people with autism and other developmental disabilities and their families. As the Associate Director of the Center for START Services, she facilitates program implementation, provides expert training and consultation services, and conducts research. Dr. Weigley is also a founder of and clinician at the Chattanooga Autism Center in Chattanooga, Tennessee. Andrea Caoili is a licensed clinical social worker with more than 15 years of experience in the field of mental health. She is the Director of Research and Quality Assurance at the Center for START Services and is also an adjunct professor in the Department of Social Work at UNH. In her work with CSS, Andrea oversees and supports START programs with meeting model fidelity and program certification, and in collaboration with Dr. Beasley, also oversees the research and evaluation activities of the center. Andrea has experience in practicing and training other clinicians in wellness-based positive interventions for persons with IDD. She is also interested in applied and participatory research in IDDMH and measurement development. Her top strengths are judgment, perspective, and love. Dr. Jennifer McLaren, MD, is the Center for START Services Chief Medical Advisor. She's an assistant professor of psychiatry at the Geisel School of Medicine at Dartmouth. She received her undergraduate degree from the University of Notre Dame, her medical degree from the University of Medicine and Dentistry at Robert Wood Johnson Medical School, and completed a residency in adult psychiatry and child and adolescent psychiatry at Dartmouth Hitchcock Medical Center. Dr. McLaren's clinical practice focuses on caring for children, adolescents, and adults with autism and neurodevelopmental disabilities. She serves as the director of the autism program and the director of the developmental disabilities clinic at Dartmouth, and provides educational opportunities for medical students, residents, and continuing medical education focused on caring for people with developmental disabilities. And finally, Dr. Jill Hinton is a clinical psychologist with over 30 years of experience working with people with intellectual disabilities, autism spectrum disorders, and mental illness. As the clinical director of the Center for START Services, Dr. Hinton provides consultation and training to START teams across the country and facilitates a monthly practice group for START program clinical directors. She currently serves as project manager for New York START and California START. Areas of particular interest include autism spectrum disorders and trauma and grief in people with IDD. Welcome, Andrea, Dr. Weigly, Dr. Hinton, and Dr. McLaren, and I'm going to pass it over to you now, Dr. Hinton.
Thank you, Beth.
Before you start, Beth, would you mind getting somebody to send the link to everyone again? Some of us had the old link and not the new link. So
Will do.
I was in a room with a few people. All right, thank you.
All right, and I think, Marianne, are you going to share the PowerPoint? So what I'll be focusing on this morning is just getting us started and kind of doing an intro and reflecting on reflecting over the last couple of days, and then beginning to what we want to do today is bring what we've learned the last couple of days into kind of the lens of START and how do we apply this to the work that we're doing every day. So I'll start with just quickly reviewing cultural competence. Next slide, Marianne. So Tuara Good provided us with a very comprehensive review of cultural competence and provided several different definitions. I've put a couple up here that seem to resonate with me, and you may have identified others that resonated more with you. But seeing culture as the learned and shared knowledge that specific groups use to generate their behavior and to interpret their experiences. And then the one that really resonates with me, I think, is the second one, which is culture is what we learn about ourselves and others from the time we are born. And from that perspective, you can see why, as human beings, we all have multiple cultural identities. And when we say we, that's inclusive of everybody, of our coworkers, of the people we support, that we all come with multiple cultural identities. And Tuara talked a little bit about how that could look different for different folks in terms of how they identify and share their cultural identities. For some folks, they may identify with one identity over the others and primarily in the way they interact with others. Some people kind of compartmentalize their identities so that some of their cultural identity is more evident when they're with their family perhaps, and less evident, maybe another cultural identity is more prevalent when they're at work. So some people kind of compartmentalize and have multiple but separate identities. And then other people really link those multiple cultural identities together. But I think the important thing about that is for us to all be open and aware, and also know that we can't make assumptions, because people reveal their identities in different ways and with different groups of people. We do know that culture impacts all aspects of all of our lives, and impacts how we see the world and how we interact and relate to each other. Next slide, Marianne. So there were lots and lots of quotes that I jotted down yesterday and the day before as we were listening. There's a couple that stood out to me. As Dave Hingsberger talked yesterday, at one point he talked about that one of our main goals is to protect the people with disabilities from our own power. And that means that we have to recognize the culture of the services systems that we're in, and historically what those cultures have brought to us and to people that we support. And then Tuara said the work of cultural competence is getting to the other side of the mirror. Both of these make me think about how, again, we have to be intentional in understanding how our service system developed, how our own culture, what we bring to that service system, and how oftentimes we've set up systems where there's a power differential and people with disabilities have acquiesced to that in some way. And I think Dave Hingsberger talked a lot about that before, is that when we say that people often want to please us or please people that ask them questions or answer the right question, to reflect on that and what that means about the way services have developed and how stressful that is for the people that we're supporting. So I think both of these make us have to stop, reflect, think about the other side of the mirror, as Tuara Good said, and really make sure that we're understanding and respecting the cultural impact of our interactions with each other. Next slide. So when we think about all we've learned over the past couple of days, and then think a little more specifically about the people that we are interacting with and supporting, people with IDD who are trying to access mental health care, we can see how disparities have affected folks. We know that that rates of engagement in mental health services are lower among underserved cultural groups. So when we think about, again, multiple identities, we know that people with IDD themselves have difficulty accessing mental health services often. And then there's the intersection with other cultural identities that folks have that can create barriers for people to access mental health services. When we don't acknowledge these multiple cultural identities, again, that creates additional barriers to care. I think one good example of this, and it came up a little bit yesterday, is there's some things we know about people that are on the autism spectrum in terms of there's been documentation and research around people with autism having higher rates of suicidal ideation and suicide attempts. We also know that autistic people are more likely to identify as LGBTQIA, and that intersection creates barriers. And then I think Rami shared with us yesterday some research that had shown that trans and non-binary youth who reported that people used their pronouns, respected and used their pronouns, that the people in their lives did that they attempted suicide at half the rate of those whose pronouns were not respected. And so when your pronouns are not respected, you're not respected. So thinking about, again, multiple cultural identities and how these can create barriers. And if you think about this across, like I said, autism, LGBTQI, having an intellectual developmental disability, trying to interact with mental health services, we can see how that creates barriers for people. And this disengagement or not being able to access services certainly then kind of multiplies and creates higher comorbidity with other issues that people are struggling with in their life. So again, what we come to this with often is we have to ensure that our engagement is aware of and respectful of and resonates with different cultural groups that we are interacting with. So we have to adjust as people who are providing that support. From the START perspective, we engage from that positive inclusive strategy, and we really have to do that and be open and aware of recognizing, respecting cultural differences in order to make sure that people are receiving accurate diagnosis, that we're adjusting our engagement, that we're aware of people's cultural identities and how that affects their access of mental health care. Next slide, Marianne. So we talk a lot about stigma in the work we do, and for us, we need to think about all these different aspects of mental health care: stigma, symptom identification, how people report what their difficulties are, how they're feeling, that culture affects all of that. So if we think about, again, people that are trying to access mental health care, especially people with IDD, all of these things come into play. When looking for appropriate mental health services, there's often a lack of training. We know that that's part of the role START has in trying to increase the community capacity of understanding people with IDD. And again, from what we've learned over the last couple of days, it is our job not only to make sure people recognize and respect the IDD when people are accessing mental health services, but they also address the other cultural identities that folks have. This lack of kind of expertise or somebody that can relate to somebody, from somebody who understands their specific experiences, can be addressed through different ways. I think the idea of a cultural broker was discussed by Tuara, and then yesterday we heard some discussion about how we might make linkages and connections with folks who can provide peer support and relate to folks from different cultural identities. Next, Marianne. So what we really want to do today is to move in, like I said, into how all of what we've learned really plays out and is reflected in the work we do as START teams. So I'm just going to briefly, we won't go through all of these, but briefly talk about the START guiding principles. These should look familiar. They're in our manuals. You've received training on them probably. So I'll talk about the principles and the values. But so thinking about what principles are, so guiding principles are really, they undergird all of our work. So they are the broad philosophy that encompasses our beliefs and our values in the work that we're doing. So they guide an organization or a system, even if specific strategies may change over time, these guiding principles are always kind of the thing that guides an organization. So ultimately, guiding principles really do create a culture where everybody understands what is important to an organization. So for START, the guiding principles, you see them all listed here. The one we've really focused on the last couple of days is cultural competence. But if you look at the others, you can see how they're definitely interrelated. And we probably brought this up yesterday and the day before too, as we talked. I know we brought up trauma-informed perspectives. We brought up person and family-centered. We brought up strength-based. All these do interrelate. But for today and from the last couple of days, we've really focused more on cultural competence. But I think the thing to remember with the guiding principles, like I said, it's the undergirding of the START program, and everything that we do is held up by these guiding principles. So cultural competence then kind of will be seen and permeates through every other thing that we do within START. So from principles, we also, if you have been through training, looked at the manuals, we also identify some core START values. So next slide, Marianne. So again, taking the concept of cultural competence and then seeing how that impacts in terms of these 9 START values that we've identified. Obviously, I won't go through all of these, but you can see that if you think about team effort, teamwork, we really emphasize the START team itself being a team, of us creating capacity in the community and connecting with other folks in the community. In order for us to work with each other to affect change, we have to recognize and appreciate the cultural identities of our team members and our colleagues. When you think about this, the people we're working with, the service recipients, the families, the same thing. We talked a lot about that on the first day. How do we recognize and respect people's cultural identities? When we're working within the community, again, in order for us to build capacity, we have to acknowledge that cultural differences exist and adapt to that diversity and how we're engaging with each other. So again, the cultural competence really pervades all of these START values. And as we move through the day, we're going to get, starting broad and moving more specific, we're going to get down to actually some of our practices. But these two kind of provide, these 2 slides, I think, provide us that backdrop of how cultural competence kind of comes through our values, and then our values are then affect how we actually practice and do the work of START. Next slide. So as you think about over the last 2 days, what you've heard, what you've learned, just thought we, take a second and think about that journey. And I think that's the other thing I think Tara really made clear to us, is that cultural competence is not a destination or a checkbox, right? It's not just a workshop, but it's a journey. And we have to work on this together, and we work on it every day. And in every interaction we have, in every type of engagement we have with the people we support, with their families, with the community, the issue of cultural competence is there, and we address it on every interaction that we have with each other. But just to kind of keep in mind that, again, there are stages in terms of kind of on the journey, but it's never a destination we're done. We never have to think about it again. It's something that will always be a part of how we work. So just, take a second to think about, what may have changed for you over the last couple of days. What new insights might you have around cultural competence from the interactions we've had over the last couple of days? And so I love this picture, but when we're thinking about as a crisis team who is a mental health service for people with IDD, if we want to address mental health, we really have to always dig deeper. And I think this slide kind of encompasses all of those things that we've talked about. We have to think about cultural identities. We have to think about oppression, racism, homophobia, injustices, and how all of those things impact somebody's worldview and in their cultural identity. So the shovel also has social justice on it. So I think that's, I know when we talked on Tuesday with Tawara, she talked about START being a social justice organization too. So thinking about how we continue to always dig deeper. We're never just looking on the surface. I think that's our goal as a START team, is to take the time to ask the right questions, to dig deeper, to recognize and respect where people are coming from. And ultimately, you know, it's a humanistic approach. We're really trying to emphasize the worth of each person that we work with, each system we work with. We recognize shared human values. And really this approach, while we're trying to dig deep and some of these things are difficult, it is really an optimistic approach. Really, we believe in the human capacity of each person we're working with. And we really want to demonstrate their resilience over these things that we're digging deep to discover and recognize about folks. So that gives us just a little brief overview from the last couple of days and kind of sets the stage for us to talk a little more specifically about how this impacts us on a day-to-day basis and START in terms of our practices. So the next slide, I think, will just kind of give us a little review. So yeah, so we're going to start, Jen will be next, and we're going to talk about, within the DSM-5, there's actually a cultural formulation interview that might be helpful to us, and Jen's going to review that with us. As Andrea mentioned, we're going to Andrea's going to provide Andrea and Karen some more information about the START specific services and practices and tools that we use, and then we want you all to really be involved in thinking some of those things through and providing feedback to us. So we're excited to be here with just the START teams today and really think about what we've learned and how this impacts how we work on a day-to-day basis. And I'm one of the people in the hurricane zone, and I'm really glad that my internet has stayed up this through this. So thank you all.
Hi, my name is Jen McLaren, and I'm going to go over the cultural formulation interview. So here's a really nice quote from a childhood icon, Mr. Rogers. And I'm going to read this to you. Anything that's human is mentionable, and anything that is mentionable can be more manageable. When we can talk about our feelings, they become less overwhelming, less upsetting, less scary. The people we trust with that important talk can help us know that we are not alone. And I think this is a great quote to remember. And when we think about talking with clients and family members and caregivers and hearing their story, thinking about that as a therapeutic encounter. And just the act of listening and letting somebody tell you what's going on in their lives is therapeutic. The other is empathy. Empathy is seeing with their eyes of another, listening with the ears of another, and feeling with the heart of another. And I hope you all bring to every clinical encounter both an empathetic and curious mind and good listening. And then a task that we've been talking about over the past couple of days is cultural competence. And you may be asking yourself, well, yeah, Dr. McLaren, I could do the empathy part, and I could be curious and I can listen, but what about the cultural assessment part? And that's where the cultural formulation interview comes in. The DSM-5 work group called the Cross-Cultural Issues Group and the American Psychiatric Association spent decades of time of work with cultural psychiatrists, medical anthropologists, developing the CFI, cultural formulation. And it really is a person-centered cultural assessment. And I think it's a good example of how to integrate open-ended questions, being a good listener, bringing empathy to a cultural assessment. It really provides a structured interview in terms of how to do this. It first appeared in the DSM-4 in 1994, and it appeared as an outline for cultural formulation. And it really was a narrative-based assessment that was widely disseminated in research arenas, became semi-structured interviews, became questionnaires, and became, in that 20-year time span, the most widely taught cultural assessment tool in mental health settings. However, the one problem with that was that it did not become widely disseminated into clinical care. Most clinicians practicing in community-based systems and academic settings were not using the outline for cultural formulation. It just wasn't structured in a way that was disseminated widely or easily usable without a lot of sort of background information. So they recognized those challenges. And when the DSM-5 came out, they had many, many meetings to talk about making a tool that was more implementable, that could be widely disseminated, and they made it free of charge. Anyone can access the CFI and use it. They studied it in over 300 patients with 75 clinicians in 6 countries. So it's considered an evidence-based tool for person-centered cultural assessments. That being said, they specifically, unfortunately, excluded certain populations from their original studies, which include people with intellectual disability. So I think we can think about how we would use this tool in START and how we may use this tool in people with IDD, but it has not been well studied in people with IDD. The CFI really, though, has meant to be used for people with all clinical encounters, with all patients, with all clinicians. And I think it's important for you all to know they also did exclude other groups besides people with IDD. They excluded, initially they excluded children. Initially they excluded people with psychotic disorders. Those were the biggest groups. And I forgot to mention this, please use also the chat for any questions or comments that you want to bring up while I'm talking. Also, the CFI really wants to take into account the influence of culture on both the assessment and formulation and diagnosis. It's meant to enhance clinician-patient communication in all clinical encounters and ideally improve outcomes in care. There are 3 components of the CFI. There's the core interview with the patient, and that can be used by itself. There's the second informant interview that can also be used by itself or together with the core interview. And each interview, if you did the complete interview of 16 questions, takes about an hour, give or take, depending on how long the patient or caregiver talks. The second informant can be anyone who knows the individual well. And then there's the last component is 12 supplementary models with lots of additional questions to expand on domains covered in either the core interview or the second informant. So that may look like that you go back and see the individual at another point in time and ask lots more questions about a certain topic that you want to understand better. So each CFI, both the caregiver and the individual CFI has 4 different parts to it. The first part is the cultural definition of the problem. The second part is the cultural perceptions of the cause, context, and support. The third is cultural factors that affect self-coping and past help seeking. And the fourth is cultural factors that affect current help seeking. We're going to go through each one of these in detail. So the CFI really does look like a structured interview where it gives you verbatim things to actually read to the individual or the caregiver. And we'll go through some of that and then they're in quotes in the PowerPoint slides. So the introduction, I think, is a really nice introduction. It says the following questions aim to clarify key aspects of the presenting clinical problem from the point of view of the individual and other members of the individual's social network, like their family, friends, other involved in the current problem. This includes the problem's meaning, potential sources of help, and expectations for services. And then in my slide, you'll see in green is what is meant to be read or said to the individual. And then in blue, on other slides, you'll see the blue text is what is meant to be said to the informant or caregiver. So the initial question to say to the individual or statement would be, I would like to understand the problems that bring you here so that I can help you more effectively. I want to know about your experiences and ideas. I will ask some questions about what is going on, how you are dealing with it. And I think this is the most important part. Please remember that there are no right or wrong answers. And here's the introduction for the informant. I'm not going to read this to you, but what you can see is the introduction for the informant is almost verbatim what the introduction is to the individual, with the exception of they change instead of you, and we'll say your family member or friend or their problem. The next question for the informant, and I ask this of everyone who comes to an evaluation with an individual, is how would you describe your relationship to the individual? And then how often do you see the individual? I also ask, how long have you known the individual, right? Because you're going to get very different information from somebody who knows someone for 2 months versus somebody who knows someone for 3 years or 5 years or 10 years. The first domain of the CFI is the cultural definition of the problem. And this is really meant to elicit what are the individual's view of the core problems and key concerns. And you want to really focus on how does the individual understand the problem. So you first ask, what brings you here today? So this is for the, right here is for the individual, and right here is for the informant. And they also give you additional probes on what to expand if you don't get a lot of information. So here's the first probe. People often understand their problems in their own way, which may be similar to or different from how doctors describe the problem. How would you describe your problem? So again, you're looking for people's sort of own language of what's their understanding of their problem. The next is you want the individual to really frame the problem in a way that they would frame it to other members of their social network. So you might say, sometimes people have different ways of describing their problem to their family, friends, or others in their community. How would you describe your problem to them? And you get really varying information here. You might hear that I don't talk about it with my family or friends, or I describe it in a very different way how they just described it to you. The next part is to focus on the aspects of the problem that matter most to the individual. So what troubles you most about your problem? And this is really key because we want to focus on how can we make what troubles that individual most better. I recently saw an individual in New Hampshire who was struggling with a combination of significant depression and anxiety, and he was a individual with an autism spectrum disorder and borderline intellectual functioning who had a significant sexual assault in his childhood. He was in his, I think he was in his late 30s, maybe, or early 40s. And he had a situation that happened more recently in the past couple of years where he had to leave a living situation. And he kept on bringing up the living situation and how difficult it was for him to leave this living situation, and was having a lot of really PTSD symptoms related to leaving the living situation. And what came out of the whole interview is what troubled him most about his problems was the loss of friends, the perceived friends in that living situation, the loss of relationships and feeling like he let people down, and not what others perceived as the traumas that he experienced. We also want to understand the cultural perceptions of the causes of the problem. In this question, the cause question, really we want to indicate the meaning of the condition for the individual, which is really relevant for clinical care. So we want to ask, why do you think this is happening to you? What do you think is a cause of your problem? And you're going to hear a variety of different things, to things based on religious beliefs, cultural beliefs, things that they've heard, or things that they just inherently believe. And then you want to focus on the views of the family members of the individual social network. And you want to hear, what do others in your family or friends or others in your community think is causing your problem? And this is an interesting question to ask people because it tells you a lot about what they're hearing as well from other people. So I had one patient who was struggling with irritability, moodability, some physical aggressive behaviors, verbal aggression, and his mom, when I asked him that question, like, what do others think of your difficulties? He came out with saying that my mom thinks I'm the devil. And he really believed that. And when we got to what did mom really believe, she did not feel that way at all, but for some reason she was calling him that. And he really internalized that my mom thinks I'm the devil. She calls me the devil. You also want to understand stressors and supports. And this is to elicit information in the individual's life context. You want to focus on what are the resources, what are the social supports, what are the resilience factors. And you may also probe about other supports. So the questions in the CFI are there any kinds of supports that make your problems better, such as supports from family, friends, or others? And then you want to focus on the stressors. You want to focus on stressful aspects of the individual's environment. You can ask about relationship problems, difficulties at work or school, discrimination. Are there any kinds of problems that make are there any kinds of stressors that make your problem worse, such as difficulties with money or family, and you can sort of change the wording here, difficulties with people you're living with, difficulties with people in your day program, difficulties with your staff. And then the CFI gets into the role of cultural identity. And this is pretty long. I would probably break this up a bit, but the wording in the CFI is sometimes aspects of people's background or identity can make their problem better or worse. By background or identity, I mean, for example, the communities you belong to, the languages you speak, where you or your family are from, your race, your ethnic background, your gender, your sexual orientation, or your faith or your religion. For you, what are the most important aspects of your background or identity? And you really want to elicit aspects of the identity that then go on to make the problem better or worse. And then there's these probes. Are there any aspects of your background or identity that make a difference to your problem? And are there any aspects of your background or identity that are causing other concerns or difficulties for you? The next part gets into domain 3, which is cultural factors that affect self-coping or past help seeking. So self-coping is clarifying self-coping for the problem. So people, you might say, and this is a wording in the CFI, sometimes people have various ways of dealing with problems like blank, like depression, like hearing voices, like anxiety. What have you done on your own to cope with your problem? You'll hear, a variety of different things. I go for walks, I'm taking medications, I'm learning different skills at their resource center. And then you want to know about past help-seeking behaviors. And here are some probes. What are other sources of help that you've used? Often people look for help from many different sources, including different kinds of doctors, helpers, or healers. In the past, what kinds of treatment, help, advice, or healing have you sought for your problem? And then you want to probe and talk about what's been useful. So what types of help or treatment were most useful? And then what was not useful? And you want to understand why it was not helpful. The next is barriers. So you want to understand the role of social barriers to help seeking, to access to care, to problems with engaging in treatment, and you want to know what's getting in the way. The question in the CFI is, has anything prevented you from getting the help you need? Like money, work, family commitments, stigma is a big one, right? Lack of services in underserved areas. And then we want to know more about what is the individual's preferences. And this is the cultural factors affecting the current help-seeking behaviors. So you want to clarify the individual's current perceived needs, expectations of help, and you want that to be really broadly defined for you. If the individual only lists one source of help, you're going to sort of cue for what else can happen. So what are other kinds of help that would be useful to you at this time? Now let's talk more about the help that you need. What kinds of help do you think would be most helpful to you at this time for your problem? This morning, I just saw an individual he was 47, and he had a mild intellectual disability and ASD. And he initially presented, both him and his caregiver, who he had been living with since June of 2019, with a concern that his medications were not treating his depression, and his psychiatric prescriber had made too many medication changes, and we needed to fix the medications. And his understanding of the appointment was that I was going to give him other medications that may help. But then when I asked him, like, what is making you so upset? Like, what is making you feel so depressed? All these other things came out, and he wanted help with all these other things. Like, he talked about losing a home care provider who he had lived with for 23 years. And he talked about that in June of 2020, his mom that lived 5 minutes away from him, who he saw regularly, had broken her femur and moved in with his sister, and he rarely ever sees her anymore. And he started crying and talked about missing his mom. And really the help that he wanted was not only maybe some medication suggestions, but feeling more connected to both his sister and mom. And I think mourning the loss of missing his previous home care provider. And then you also want to focus on the views of the social network regarding help seeking. So are there other kinds of help that your family, friends, or other people have suggested that would be helpful for you? It's also helpful to, when you ask that question, to then follow up with, well, what do you think of those suggestions? And then you want to elicit any possible concerns about the clinic or the clinician-patient relationship. You want to get more details about that, and you want to really address any barriers to care or concerns. So the probe in the CFI is, have you been concerned about this? Is there anything that we can provide you with in terms of the care that you need? I do have a short video that was put out by the CFI that models a portion of the cultural formulation interview. But before I show that, I just wanted to see if there was any questions that I should address in the chat.
Hi, Dr. McLaren. There was one question about this information and the intent of sharing this information. Is this applicable to START coordinators when they're doing an intake, or is it more so for therapists or psychiatrists who are doing med management?
That's a really great question, and thank you for clarifying that. This interview is meant for, and I think you want to think about it as making I would use it as the initial encounter, right? The first time that you may be meeting the patient and doing a clinical interview, using portions of this, or if you feel like it's appropriate, all of it is meant to be a part of a person-centered cultural assessment. So it's meant for any type of clinician that's doing an evaluation or initially interacting with a patient. So not just psychiatric prescribers or therapists, it could be utilized by START coordinators, care managers, community mental health workers, case managers, service coordinators. It's not just meant for psychiatrists.
Thank you. That was the only question.
Okay, so let's watch.
I actually had one.
Yeah.
But it came in late. It's Joni. Hi.
Hi.
I'm thinking, what do you think about the idea of developing some sort of a modified version in plain language.
I was
that we
hoping
can
somebody
use
would ask that.
because
I
I think
think
that's what you want, right, Dr.
that that is a genius idea. And I was, preparing these slides. I was like, I hope somebody's gonna bring this up because it's really needed. Gosh, right? And I was just blown away when I was reading more about how they developed the CFI that they excluded this patient population.
Exactly, which is the story of our lives, right? And the lives of the people we support. But it doesn't, so for those of you who are new to START, this is what happens. You find these methods. Someone like Dr. McLaren, who's our fearless medical leader, brings it to us and says, this is the method. It hasn't been tested on our population. And then our job as a community is to consider that and see whether or not we should look at all that they've learned on how to do this and figure out how to make it more accessible. So I think that it sounds like something we should really think about. Yeah.
Absolutely.
The other thing, I mean, the other thing I would add is a couple of questions that are similar, but focus on the strength, like what strength have you used in the past, or how, what does your family see as your strength? I don't know, a couple of them, just switching and adding a couple of questions about strengths too.
Right. Like if you listen to Angie's talk from El Paso on Latino and Hispanic culture, she'll talk about some of the myths associated with having mental health issues for the people we support, but she'll also talk about some of the cultural strengths in supporting people with IDD and mental health issues that particular culture has to offer. And I think you're right, Jill. I think it would be a very interesting thing to do, to include that. Yeah.
Absolutely. You know what? I'm going to hold off on showing the video because it's accessible where you can download the CFI, because we're right at the time of where we should be transitioning to something else. And the video, I think, is a good example of how they word the questions, because they actually word the questions verbatim. And the video is with a typically developing adult. So I'll let you guys all access the video at another point, and I think we'll move on to the next speaker, which I think is more relevant to the START programs. Oh, I just want to close though. Forgot about this last slide. There we go. The CFI, I really want you to think about that. It gives a comprehensive framework for a person-centered cultural assessment. It gives you a framework to not make assumptions, to ask open-ended questions, to really listen and understand the individual's experiences, to help you be, and remember to be curious, right? Just if you're going into a setting where you don't know a lot about the individual's culture, you think about this as a learning opportunity to be curious, be caring, humble, respectful, and always remember that letting someone tell their story is a therapeutic experience. Thank you.
Thanks so much, Jen. And just so you all know, we do have, I know you all did not receive this PowerPoint before the presentation today, so that will come to you along with a link to access the cultural formulation interview and the links for the videos and all of those sorts of things. So thank you so much, Jen, for pointing us in that direction. We'll make sure that everybody gets those resources. All right, so I am also another person on the team that is potentially being impacted by power outages. So we're gonna cross our fingers that we're all good for the next little bit. And I was so happy to be asked to talk to you all today about doing START work through a culturally competent lens. What we're gonna cover here is really just an overview of the core START practices and services of START. You'll get a much more in-depth deep dive in other training opportunities, especially you new programs. There's by participating in the coordinator training curriculum and other training and technical assistance that will be provided by your project manager. But what we're gonna do here today is really talk about how to apply specifics, how to apply a culturally competent lens to specific START practices. And then we're going to have an opportunity to actually talk to one another about that, because there has been a lot of opportunity to listen, and we want you all to also be able to dialogue. So just before we get into that, I want to talk just real briefly about how START applies the World Health Organization's public health model for tertiary care. So this is the conceptual framework that we use at START. It helps us to structure and organize the services and supports that we provide, and sets the stage for START programs to maximize the use of resources for the people that they're supporting. So you can see here that there are 3 levels of intervention: primary, secondary, and tertiary. And each of these are necessary to assure a continuum of care. If we skip any one of these levels, then we ultimately end up with a gap in services and supports that can really impact those that we're serving through START, and also the IDD community as a whole. So in terms of primary interventions, those are capacity building activities. Those are things like linkage agreements, CETs, community-based trainings that are provided by START to the community. Secondary services are those proactive planned services that we provide, such as crisis planning, intake assessment activities, planned therapeutic supports like therapeutic coaching and outreach, things of that nature. And then the tertiary interventions that we provide at START are acute responses to a stressful situation, where our primary goal is to stabilize and to maintain safety for people that are enrolled in services. So that's where 24-hour crisis response comes in, and emergency therapeutic supports. And one thing that I have really been thinking about over the last couple of days is how important it is for each of these components to be present in the context of START service delivery, in order to make sure that we maintain a principle of START, cultural competency. If we miss any single one of these levels, it actually changes the structure of the framework. So if we take away tertiary intervention, for example, and we don't provide services when perhaps people need them the most or the most vulnerable, then it changes the shape. We end up with, I think it's like a rhombus or something like that. I'm not exactly sure. It's not a parallelogram, but I know it's not a triangle anymore. If we skip primary intervention, we still have a triangle, but you can see that the surface area shrinks significantly, which means that we have less impact perhaps on the community as a whole. And if we take out secondary services, those planned services, and we only provide training and tertiary intervention, then we end up with 2 separate services that have no way of connecting. So we really need to make sure that we're applying primary, secondary, and tertiary intervention at all times, so that we maintain continuity. And I'm going to start with just a little vignette. I'm going to read this to you, and I just invite you to spend a couple minutes thinking about it. We're not going to share out necessarily, but I do encourage you to put your thoughts or comments in the chat. And what we'll do is, at the end of this session, because there's going to be some other opportunity for sharing, is we'll pull all of that together and we'll send it out for folks in a note. So a couple things to think about that I want you to think about here as I'm reading this vignette. What cultural factors might be considered here? What kind of feelings would this bring up for you as the clinician? And how might you work with a team that might be frustrated by a situation such as this? You advocated for a child and family you work with to get an appointment with a well-respected psychiatrist in your area. The psychiatrist has a long waiting list, but they agreed to see the child. The child was prescribed medication to address a behavioral health issue. You learned that the parents got the prescription filled, but haven't given the child any of the medication. Upon further investigation, you also learned that the parents did not schedule a follow-up appointment as recommended. So just take 15, 20 seconds here and reflect on this vignette and think about those 3 questions. What cultural factors might be considered here? What might you feel as the clinician who advocated for this appointment? And how might you work with a team if something like this were to happen? And as we go through each of the START services that we're going to talk about today, I want you to just sort of keep this situation or other situations like this that you might have experienced either in your work as a START team member or elsewhere that might be relevant to what we're talking about today. All right, so one of the core primary level interventions of START programs are linkages. Linkages are partnerships that allow for sharing of information and resources to positively benefit those engaged in services and also the community as a whole. So as a START team, it's important to have a national perspective because that certainly impacts your local community. But what you really want to do is have a deep understanding and seek a deep understanding of your local community's diversity. There's a need to establish cooperative partnerships with culturally diverse service providers, resources, community figures and leaders, those grassroots organizers and other cultural organizations in your community. And then with that, you want to make sure that you build an advisory council that represents your community. You need to look and see who plays an important role in my community and make sure that they have a voice at the table as a member of your advisory council. I also want you to consider the role that you play as a START team member as a cultural broker. We learned on Tuesday from Tawara that no matter what, we all have a culture. We all have multiple cultural identities. It means something to us. We also learned and heard from Dave that the answer is not always more services, more services, more services, or more training, more training, more training. It's really treating people with respect and dignity. And so cultural brokerage sort of pulls all of this together and pulls all of those lessons together and helps us put it into practice. Cultural brokerage is when a person facilitates the mediation or bridging between two different cultures. So in healthcare or human services, like START service delivery, the service provider often plays that role. And they help people navigate these often quite complex systems of care and serve as guides and supporters in navigating these systems. And in terms of START service delivery, there's often multiple systems that you're navigating, right? You're navigating the IDD system, mental health system, sometimes child protective services, APS, educational system, criminal justice or legal system. So there's a number of systems that you have to know enough about to help the people that you're supporting to navigate. And having strong linkages in place really leads us to effective secondary services. And the intake assessment portion, the intake assessment is often the first look that you have into, it's the first opportunity that you have to really get to know a family and a person that you're serving. And so then that means that it's really important to make sure that you gather the right information. But in order to gather the right information, you have to ask the right questions. And some of what Dr. McLaren just talked about sort of set the stage for asking some questions that can really get to an understanding of who the person is and how they see the world. Those are called open and honest questions. Okay, open and honest questions are questions that convey to the person that you really have no agenda here other than to learn about their perspectives and what they feel like they need. These are questions that only the person or the family knows the answer to and really gets to the heart of who that person is and their worldview. So here's a couple examples of open and honest questions. Who do you consider as members of your family? What holidays do you celebrate? What types of things do you do together? What are some things that are important to you? I remember when I was meeting some extended family of Filipino descent for the first time. My spouse is Filipino, and I was meeting a number of his family members, and everyone was introduced to me as auntie or uncle. And I remember looking at him and saying, man, you're related to a lot of people. Your family's huge. And he kind of looked at me and laughed, and he was like, I'm not related to all these people. I'm connected to them. They're my family, but I'm not related to them. And I just thought, man, that really tells me a lot about who this person is and what the Filipino community is like in that part of the country. And so those are the types of things that you might want to ask to get to really the heart of who this person is and who their family is. So I invite you again to use the chat and just toss in some open and honest questions that you might ask at intake. You can reframe some of those cultural formulation interview questions, like Jill had said, to get to the heart of the strengths of the person or the family, and just share them in the chat as we sort of continue to move forward. The second secondary service, that sounds funny, but the second secondary service that I want to talk about is outreach. The primary goal of outreach is to join with the person, with their family and their team, so their system of support, okay? And in order to do that, there has to be some level of mutual trust, respect, and empathy. So I'm going to read this quote to you, and I want you to stop what you're doing and just listen to this, okay? Empathy is a key skill in cross-cultural competence. Empathy helps us to shift our thinking, to see things from other perspectives, and to really imagine thoughts and feelings from another person's point of view. There's a few key phrases here that I want to repeat. Shift our thinking, other perspectives, imagine thoughts and feelings, and another point of view. By doing these things, you are engaging in empathetic and culturally competent outreach practices. I think that this really goes without saying, but I'm going to say it anyway. Differing cultures isn't a problem. In fact, understanding these different cultures actually help you as the START team member identify the key ingredients for success. This is where strength spotting comes in, folks, right here. Certainly that permeates every single thing that we do at START, but you can see how it would pop right in here, right? As START team members, we need to seek to understand how people and families view certain issues based on their cultural lens, because how I view them, I need to be really careful that I don't impose my views and my opinions on certain things on this family. Dave Hinsberger reminded us of that yesterday, right? He said, who am I to bring my opinion to the table? And when we do this, then we are able to modify and adjust our services and supports to align with those values. Here's just a couple of examples listed here where there might be a disconnect in how you as a service provider and how the family might view these things. Some people really value independence. Some value interdependence. Some value collaboration. Some don't. In my family, I was taught that the doctor's always right. You don't question them. But in other families and other cultures, questions, exploring, researching on your own is really valued. And we need to be able to understand those differing perspectives. And this last one, certain service engagement. If you think about the vignette that we just talked about, I wonder if there was a disconnect between between the clinician and the family around the value of psychiatry and the use of medication. I'm not sure, but these are the types of things that we need to understand. I was struck yesterday when Dave said that he often gets heart questions or human questions rather than physical questions when it comes to sexual expression and things of that nature. And he also said that really points to the humanness of everybody and the humanness of those people that we're supporting. And so that's what we need to convey through our outreach. We need to always convey respect and goodwill. We need to acknowledge very sincerely a desire to learn about the family and their lens and their point of view. And when we're able to, we want to be able to refer families to culturally appropriate services. But let me tell you, you need two things in order to do that. One, you need to know where to find them, and that starts with linkages. And two, you need to have a joint understanding of what the plan of action is, which starts right from intake. So as you can see, each of the START services sort of build on one another. And as a way of enhancing what we do over time. So if we don't have strong linkages and we didn't really engage in gathering data or gathering information right from the beginning, then it may be difficult to do this when we get to the point where we are providing regular outreach. And, you know, there's a lot of value in having service providers who speak the family's preferred language. I recognize that that's not always possible. I speak English. I don't speak any other languages, although I know a lot of most curse words in Italian, and also the names of a lot of food in Italian. My grandparents, their preferred language was Italian, and that's what they spoke. But I did not learn that language. And so when this isn't possible, we need to seek interpreter resources, and you need to know where to find them. So I want you all to really think about that and ask yourselves, do I know, if I need to, where to access these resources? If I am on call tomorrow and I need to access these resources, I will know what to do. If the answer is no, that's okay. That's why I'm asking the question. Figure it out. Just work with your team and come up with and figure out where those resources are. It's really important. This should go without saying, but I'm going to say it because it happens way too often. Members of the family, and especially children, should not be used as interpreters, folks. We need to seek outside resources for that. It's not the job of the family to interpret for us. We talk a whole heck of a lot at START about reframing. Let me tell you what reframing is not. It is not finding a nicer way of saying something that isn't super nice to begin with. It is not using START language versus regular language, okay? It is about using language that is constructive, helpful, and language that shifts things from a problem to a constructive potential solution. That's what reframing is. It's creating a different way of looking at a situation, a person, or relationship by changing its meaning, not replacing it with a synonym. Reframing helps us view challenges in a more positive, constructive light. We need to rethink the questions that we ask and make sure that we're asking the right questions. So it's not, what do we need to do to get Andrea to stop going into crisis? It's what do we as a support team need to do to make Andrea feel more secure and safe, right? That's the reframe. We need to unpack our assumptions, because guess what? We don't know what other people are feeling. We're not mind readers. And when we infuse our assumptions into a situation, that's exactly what we're doing. And the other thing that we need to do with reframing is we need to be actively listening. That means being present. That means not throwing out a solution too quickly. It means asking open and honest questions. And it means that we are not asking a question and then immediately thinking about our response. We're actually listening and hearing what people have to say. That's what reframing is, not a synonym, folks, not a synonym. And so all of these things, effective outreach, developing trust right from the beginning, getting good information and knowing where to go for resources, really sets the stage for effective crisis planning. People react to stress and crisis within the context of their own individual backgrounds, their experiences, and their viewpoints. That means that they will express emotion in different ways, that we will describe symptoms in different ways, that we might try to cope with situations and experiences in different ways. The more we as START team members seek to understand the lens in which the person is viewing the crisis, the more effective we will be in supporting them through that. We also we need to recognize that there are structural barriers. There are man-made structural barriers that are put in place that impact a person and a family's openness to support during a crisis. Racism, discrimination, inequities. It all too commonly comes up that we don't want to involve the police because we are scared that our loved one is going to get hurt or arrested when really they need help. It is all too common. So by understanding the perspectives or trying to understand the perspectives of the people that we're serving, we can do our best to mitigate some of this. Crisis planning is and can be culturally competent when we build trust, when we are empathetic, when we respond in a timely way and in a consistent way. So interventions need to be built on safety and reassurance, not redirection, and they're certainly not contingent on behavior. Because I, for one, have certainly acted in a way that I wasn't super proud of when I was really stressed, right? And with crisis planning, there is zero blame put on people. If there's a crisis, it's a failure of the plan, not any one member of the team. That's why at START, crisis planning never ends. If there's a crisis, we immediately get together, we talk about it, we debrief, we learn from it, and we revise the plan. There's no blame. And so therapeutic coaching is a tool that we can use to enhance the efficacy of the crisis planning process. It can be used as a building block to learn more about the family and the person and how they might handle stress. And then we can design interventions that promote strengths and resiliency and safety over time. So therapeutic coaching is provided in the person's home or their environment, in their job, at their day program, at school. It is done in the person's environment. Therapeutic coaching is supportive, it's intentional, it's participatory. So we don't develop goals in isolation. We develop goals with the person, with their family, and with their team. And those goals are aimed at strengthening the person and the family's unit ability to live a happy life. And all of those secondary services set the stage for effective crisis intervention. As a START team, you respond to crisis 24/7. You're always there to help. So having the right linkages in place, knowing the community resources, having a comprehensive intake process, and crisis planning allow for effective intervention and timely intervention in an emergency when needed. There is zero judgment in a crisis situation, and there's no wrong way to contact the crisis team. What we do in a crisis is we let people know that help is on the way. We show up. We go. Because being there with people and letting them know that we're here to help, even if we don't have all the right answers, is really, really goes a long way. And if what we are trying so hard to do in terms of provision of secondary services, building rapport, trust, and capacity building, if we don't show up and people don't feel like we're there to help, then that can undermine all of that, which is not what we want to do. And I guess I sort of see, I put CET CSE at the end here, even though it's a primary service, because I feel like it's a community capacity activity that sort of brings everything together. So if I think about, I know we talked about how the tertiary care model is a framework for how we see START services. I also see it as a continuum. So we have linkage agreements, which impact secondary services and emergency response. And that brings us right back to the top for capacity building. So it never ends. We're constantly using the information that we gather to inform our next steps. And so the goals of the CET CSE process is really two things. One, to draw on expertise from an interdisciplinary team to identify innovative strategies to support the person, and two, provide training to community partners through a case review, right? So we use what we've learned through all of these steps. We use an interdisciplinary approach and a cross-cultural approach, and we brainstorm and we identify potential interventions. We don't mandate that those interventions need to be implemented. We take that back to the team and we discuss that. And then we also invite community partners so we can learn together through this case review process. And what we do is we identify ways to generalize what we're learning to apply to other situations. And that's how it becomes a capacity building activity. And it sort of brings everything full circle. So like I had said, that was a very quick overview of the services and supports that START provides, but it was important to do that and to frame it in such a way through a culturally competent lens, because that's what we've really been talking about over the last couple of days. What I want to do now, and what our presentation team, wants to do now is we want to give everybody an opportunity to dialogue. So we are going to break out into small groups. Every group has a moderator. They already know who they are. And so you will be put in a group with a moderator. They will have the questions that you guys can discuss. And you have maybe, 20 minutes, 25 minutes or so. I would like, if you likely don't all know each other, so spend a couple of minutes introducing yourselves. And then really take a deeper dive into some of this stuff and think about and talk about how what you've learned over the last couple of days might truly impact your day-to-day work at START. Identify one member of the group to report out. And when we come back, we're going to get through as many as we can. We may have to randomly select people, but what we'll do is your moderators are going to take notes and they're going to send them to us. And we're going to make sure that it all sort of gets put in one place so we can hear what everybody has to say.